Welcome to the best bite-sized video on clinical examination of the unstable shoulder. Before commencing examination, a clear history of the onset of the problem is required. It is important to ascertain where the patient sits on the Stanmore triangle of instability as to whether they've had a traumatic incident leading to a dislocation or whether they have hypermobility and potential muscle patterning. Take time at the start of your assessment to observe the patient. Assess posture, assess scapular position, look for any winging or difference in shoulder height. Ideally, undress the patient and assess for any obvious wasting, especially in supra or infraspinatus fossa, and have a look at waist creases to see if the shoulder is depressed or elevated. Baton score should be reviewed to assess for any hypermobility. A score of 4 or above is generally considered hypermobile. But do remember, patients can have local laxity in their shoulder and would present with external rotation of 90 degrees or over. The 9-point scale includes touching the thumb to the forearm on each side, extending the little finger to be parallel with the forearm again on each side, hyperextension at the elbows evident at both sides, knee hyperextension at both sides, and the 9th point, putting the hands flat on the floor. When assessing movement, both the range of movement and also the quality of movement and muscle patterning needs to be assessed. Ask the patient to actively demonstrate forward flexion to their full capacity, taking the arms out into abduction, again into full capacity, putting the hands behind the back, comparing sides but also looking for any trick movements, and external rotation. Consider any difference in ranges and also what they're doing to achieve that movement. Note this patient is struggling to externally rotate his left arm, so retracts at the scapula. Observe for muscle patterning. In this patient with posterior instability, he subtly depresses the shoulder, lacks scapular protraction, wings on lowering of the arm. She can also be noted that she rolls into internal rotation. The humeral head can be seen prominently as she subluxes posteriorly. This patient again leans back, lacks scapular protraction and posteriorly dislocates and has to relocate. Assessing the rotator cuff power and function. Supraspinatus can be assessed in the empty can position. Assess power and if any overactivity in the pecs or lats. Infraspinatus assess external rotation, looking for compensation, especially by fixing into abduction. Subscapularis can be assessed by a belly press test. If a patient is struggling to achieve active external rotation, assess for lag signs. Instability tests can be useful to assess laxity in the shoulder and direction of instability. Salker's sign may be present. In this patient, it can be seen the patient can achieve this themselves. However, as shown, if we take her into external rotation and assess Salker's sign, this is corrected, which can suggest a lack of surgical target. The anterior apprehension position, taking the arm into abduction external rotation with a positive test when the patient feels at risk in this position. The posterior apprehension test, the arm is taken across the body and can be loaded from the elbow posteriorly. Again, a positive test is if the patient feels at risk in this position. The patient should be assessed in a weight-bearing position to assess proprioception. Assess whether they can fully weight bear on that arm, whether it differs from the other side. Have a look for scapular winging, which in this case you can see medial border scapular winging, and he's locking the elbow out to try and stabilise. In this patient with hypermobility, again you'll see she locks her elbows into hyperextension to try and gain support. When taking her into single arm loading and asking her to bend the elbow slightly, she struggles with this. With this patient, she's able to weight bear quite confidently through her right arm, but when she loads through her left arm, you'll see she locks out the elbow. It is not as stable and struggles on this side. If a patient presents with muscle patterning that is contributing to their instability, improvement tests can be used to see if their quality, range and stability during movement can be corrected or improved. In this patient we saw earlier, who lacked scapular protraction, asking her to step forward and hitch the shoulder, putting a cup of water in her hand to prevent her from rolling in. And she can achieve a much more fluid movement and feels more confident moving the arm and is no longer subluxing posteriorly. So this can be used as an exercise for her to work on and practice. This patient who was posteriorly dislocating at 90, hitch in the shoulder girdle enables full range of movement. Any patient with muscle patterning will require physiotherapy, whether they have a traumatic onset or an atraumatic onset, with their baseline physiotherapy treatment being dictated by the assessment. Thank you.